Thanks to Inas for the invitation and to Abbott as well for supporting this very interesting program. So we have quite sharp times and we want to keep time for discussion. So let me start right away. We are discussing what hormone therapy for menopausal women can do in different areas. And my topic is glucose metabolism. So let me start by saying that it's well known that at the time of menopause, there's a metabolic change which leads to increased visceral adiposity, increased waist circumference, and this has an impact on metabolism. So this is how women change across the menopausal transition, being thinner before menopause and becoming a little bit more like us male, tending to accumulate fat in the abdomen after menopause. Now this change has multiple reasons, and I won't go into the pathophysiology of why this happens because this is very complex. But this change leads to an increase in body weight and central adiposity. It needs to be approached with severe diet and lifestyle advices in those persons where this is more severe, and because it brings metabolic alterations like insulin resistance, lipid metabolic disorders, and in the end, increased risk for cardiovascular disease. So the topic is menopausal hormone therapy. What does it do on glucose metabolism? And I will try to touch on some of the points that you see on these slides during my presentation. So first of all, it has been observed and now measured a little bit more specifically, more objectively in a large cohort in a couple of years ago, the Osteolaus cohort, that those women who use menopausal hormone therapy across the menopausal transition and throughout the aging process have less accumulation of fat, and particularly less accumulation of visceral fat. So in these graphs, you see those white graphs depict the behavior, the fat accumulation by current users of MHT, the light gray, the past users, and the darker gray, the never users. So the never users accumulate much more fat in the abdomen than users of HRT. And in this same study, one can see that the amount of glucose in the bloodstream is not that different in this population. But in current users, which is the third right column, the amount of insulin circulating in fasting condition is much lower than in non-users. So these women seem to be more insulin sensitive, and the HOMA index is better than the non-users, confirming the relevant impact of HRT or menopausal hormone therapy on insulin biology and metabolism. There's a quite dated meta-analysis, but it's still cited a lot by Salih-Salpeter and the group. It's a big meta-analysis published in 2006 that reports on more than 100 prospective studies that discuss the effect of menopausal hormone therapy on diabetes. And what it comes from these very solid studies is that in women without diabetes, MHT decreases a lot of things, including abdominal obesity, insulin resistance, but mostly new onset diabetes. And in women with diabetes, MHT decreases insulin resistance and fasting glucose. So it doesn't have any bad effect on the control in women that need therapy for diabetes. This is the PEPI trial, one of the oldest observational trials that we have available, published in the mid-90s of the last century, as we say, depicting again in this large population observed for many years how insulin levels in those women who use estrogens are better, lower than in those women that do not use estrogens. In a different graphical form, you can also see that, however, menopausal hormone therapy may have different impacts on glucose metabolism, and particularly in this case on non-fasting blood sugar levels, based on the presence or absence of a progestin. You do see that those women who use, in a PEPI trial, conjugated equine estrogens have lower blood sugar levels than those women who use contemporarily conjugated equine estrogens and medroxyprogesterone acetate. And however, if you use micronized progesterone, this effect is blunted. So this is one of the first suggestions in our a recent history in clinical trials suggesting that progestins might make a difference also on glucose metabolism. Let's see insulin sensitivity. This is another comparative trial done by the group from John Stevenson, published in 2000, where you do see that the same type of estrogen provided with the same progestin, norethistron acetate, but through different routes, transdermal or oral routes, does make a big difference on insulin sensitivity, with the oral administration be better because the insulin sensitivity is improved, showing that part of the effects of estrogens in terms of glucose and insulin metabolism are mediated by the liver, and therefore the first passage liver effect might be relevant. So, how do estrogens and progestogens work on glucose metabolism? What do we know? So, to make a very long story very short, we do know that in the brain there is a lot of estrogen and progesterone receptor and androgen receptors, but in the hypothalamus particularly, estrogens act through ER alpha to suppress food intake, to stimulate physical activity and energy expenditure, which of course is extremely important in terms of keeping the body shape and the amount of fat and not making it improve. And again, so there's a lot of pathways that have been identified. This is a paper published by François Mauvais-Jarvie, and a big expert in diabetes and estrogens, that show that how estrogen can improve peripheral energy and glucose homeostasis. I'm not going through all the points. You can look at them on the slide. But overall, there's a multiple amount of mechanisms through which estrogens and the receptors act. Both the estrogen receptor alpha and, as you can see in this slide, estrogen receptor beta, how they do activate peripheral energy expenditure, which is, of course, very important for weight gain, fat accumulation, and, of course, glucose metabolism. And the data that we have, this is another very large big paper published very recently in Diabetes and Metabolism Journal, showing that in a big cohort of women, there's insulin sensitizing properties of estrogens provided as menopausal hormone therapy, and effects of estrogens on insulin-mediated glucose uptake, signaling, and glucose transport in adipose tissue and muscles, which is very important. So this is the data from the population in the study. You do see that these women who were actually diabetics, so this was not healthy women, these were women with type 2 diabetes mellitus, in a model assessing insulin resistance, well, the administration of menopausal hormone therapy decreased by 36% insulin resistance, supporting those data that we saw before from the meta-analysis from Sally Salpito. So what we discuss about progestogens, however, the story becomes much more complex. We have so many progestins and only a few estrogens. Estrogens have been much more studied to this extent. But progestogens as a family, as a whole, have been associated with insulin resistance. So they look like the bad brother as compared to estrogens. However, there's a lot of differences based on the progestogen type. And you all know how many families of progestins we have, and the chemical moieties are very different. And this makes a difference in cells because these different compounds can bind to progesterone receptors in different ways, and to non-progesterone receptors like androgen receptor, glucocorticoid, or mineralocorticoid receptors, and providing multiple signaling effects in cells. So each progestin has a very specific, peculiar way of modifying the metabolism in cells. So if one wants to make a very long story short, what we know about progestogens on glucose homeostasis is that oral androgenic progestogens tend to increase insulin resistance. Transdermal norethistron acetate, as you know, it's the only transdermal progestin available, has little effects on insulin. And this is, of course, need to be taken into account that it also goes along with the transdermal estrogen administration. MPA, medroxyprogesterone acetate, as we have seen in the PAPI trial before, has adverse effects on glucose and insulin, possibly also because of its glucocorticoid effect. Progesterone, natural progesterone, or molecules that are similar to progesterone, like dihydrogesterone, indeed tend to have little adverse effects or no adverse effects on glucose and insulin. And I'd like to show you here a couple of studies, again, one from John Stevenson, showing that women receiving a combination of estradiol and dihydrogesterone tend to have, over 2 years, progressively improving amounts of insulin and slightly also of C-peptide, showing improved insulin sensitivity. And again, in this second study by Gottsland, once again, a cohort with a low dose sequential estradiol dihydrogesterone combination, showing again stable fasting glucose levels but decreasing fasting insulin levels, suggesting improved insulin sensitivity in these women. So therefore, the big take-home message is that when one wants to discuss about the effects of menopausal hormone therapy on glucose metabolism, one needs to discuss about the route of administration, the type of combination, which progestin, which estrogen, the dose, because they all impact metabolic outcomes. And my concluding slide is that overall, menopause tends to have a worsening effect on glucose and insulin metabolism. Menopausal hormone therapy has no detrimental effects on glucose and insulin metabolism in general, and it seems in big numbers to prevent fat deposition and the risk of developing type 2 diabetes. Now, there are significant differences related to the effects of glucose and insulin metabolism based on the type, dose, and route of administration, as we have said, but the type of progestin is also one critical aspect, with androgenic progestins being associated with adverse actions on glucose and insulin, while progesterone and dihydrogesterone seem to be neutral or beneficial, as we have seen in these last two studies that I showed. So therefore, an appropriate MHT could lead to metabolic benefits in postmenopausal women, also in terms of glucose metabolism. I'd like to thank you, and if there's any question, I'll be very glad to answer.
Dear colleagues, first of all, I would like to thank the organizing committee for this session, for this hormonal invitation. In the next 10 to 12 minutes, we will discuss about the effect of menopausal hormone therapy on lipid metabolism. There is no conflict of interest to disclose. The outline of my presentation actually focuses on three topics. The first, we will discuss about the metabolic changes during transition to menopause. Second, and most important, we will discuss about the effect of menopausal hormone therapy on the lipid profile. And finally, we will give a kind of guidance, a kind of clinical approach to the postmenopausal woman with dyslipidemia. With regard to the first topic, it is well known that transition to menopause is associated with an increased atherosclerotic risk profile. This is mainly attributed to dyslipidemic lipid profile converging that seen in men, which includes mainly the increase in total and LDL cholesterol as well as triglyceride levels, converging and sometimes exceeding those seen in men. There is also a decrease in high-density lipoprotein cholesterol involving mainly the HDL2 subfraction. There are also some other lipid changes that involve the increase in apolipoprotein beta, as well as the ratio ApoB to ApoA1 and LDL cholesterol to ApoB. And there is a slight or a neutral effect of menopause on lipoprotein little a concentrations. We must remind that lipoprotein little a has been recently recognized as an independent atherosclerotic risk factor. There are also some other metabolic changes that were also mentioned by the previous presenter, such as the increase in abdominal fat, the increase in insulin resistance and blood pressure, and last but not least, the increased prevalence of non-alcoholic fatty liver disease. All these converge to an increased atherosclerotic risk seen while women enter menopause. However, this has not been translated into an increased risk of cardiovascular disease events, which has been shown in women with premature menopause and premature ovarian insufficiency. That means that it is not currently known if this lipidemia and the other atherosclerotic risk factors or associated with menopausal transition are also translated into an increased risk in cardiovascular disease events. With regard to the second topic, we will focus on that. Estrogens are the main component of menopausal hormone therapy, and the estrogen either as oral or as transdermal preparation exert a favorable effect on lipid profile. This includes a decrease in total and LDL cholesterol, as well as an increase in HDL cholesterol. We must mention that it has to do with a kind of dose-dependent effect. It is more pronounced in patients with high baseline total and LDL cholesterol concentrations. It is greatest with the conjugated equine estrogen, and as you can see, it is greatest with oral preparations compared with transdermal. You can see this table according to a very well-known and thorough systematic review by Professor Gottsland, that you can see the mean percentage changes in conjugated equine estrogen in different doses, conventional and high dose. You can see about a 15% increase in HDL and 18% with the highest dose, and quite a 12% decrease in LDL, a minor decrease in total cholesterol, and an increase in triglyceride levels, and we must keep this in mind. You can also see these changes to a lesser extent with 17-beta estradiol. This is also dose dependent, but what is of utmost importance is that when we use transdermal estradiol, we may see to a lesser extent these favorable changes with regard to HDL and LDL, but we have also a decrease in triglyceride levels, or either a neutral effect with higher dose. This is the usual conventional dose used in menopausal hormone therapy, 50 micrograms per day, whereas with 100 we have a minor or a neutral effect on triglycerides. This is very important and must be taken into consideration. The favorable effect has been also seen and proved in another meta-analysis. As you can see here, there is a decrease, an absolute decrease of 12 milligrams per deciliter in total and LDL cholesterol, while there is no increase in, there's no effect on HDL and triglycerides. According to quite a recent meta-analysis that which we published in Maturitas in 2017, this highlights the beneficial effect on Lp(a). We must keep in mind that there is currently no effective medication on Lp(a) except for estrogen. As you can see here, there is about 20% decrease in Lp(a) concentrations, and these are higher with oral compared with transdermal preparation. Triglycerides, as I mentioned before, increase with oral. They may either decrease or remain stable with transdermal, whereas Lp(a) decreases about 20 to 25% with oral, and to a lesser extent with transdermal. There is no effect of estrogen on ApoBeta levels, and there is a beneficial effect on ApoA1. This is the main component, the main apolipoprotein of the good cholesterol, of the HDL cholesterol. What about progestogens? In general, there is little effect on this beneficial estrogen-related decrease in total and LDL cholesterol. However, with regard to HDL and triglycerides, norethindrone may decrease HDL and triglycerides, whereas this is neutral concerning micronized progesterone and dydrogesterone. With regard to medroxyprogesterone, there is unclear effect on lipids, whereas there is no effect at all for intrauterine levonorgestrel, which is also used. With regard to tibolone, which is also used and exerts both estrogenic, progestogenic, and androgenic effects, you can see here the beneficial effect on total cholesterol, triglycerides, and Lp(a), but there is also a detrimental effect on HDL cholesterol. And as you can see here, there is a 22% decrease in HDL cholesterol with tibolone, whereas there is a kind of beneficial effect of total cholesterol and on triglycerides, but what is most important is the decrease in lipoprotein little a, which is also dose dependent. With regard to the combination, as we call it the TSEC, that is conjugated, low-dose conjugated estrogen with dapagliflozin, we can see the same effects as with oral estrogens, as I mentioned before, well, to actually a lesser extent. There are actually slight or subtle differences with regard to vaginal estrogen, either as a ring, as estriol, or as creams or gels or whatever. You can see a slight decrease in total and LDL as well as ApoBeta concentrations as with oral estrogen, but there is no effect on HDL and triglycerides. I must also mention some non-estrogen-based therapies which are also used in women, such as for those with vulvovaginal atrophy. We can use ospepifen. It is a well-known selective estrogen receptor modulator. You can see a kind of decrease in total and LDL cholesterol and increase in HDL and no effect on triglycerides. This is also the case with vaginal dehydroepiandrosterone, which is a kind of androgen with not so strong androgenic properties like testosterone, but it can be used for vulvovaginal atrophy. There is no effect on LDL and triglycerides. With regard to testosterone, it can be used in women with hypoactive sexual desire disorder dysfunction. We do not use oral testosterone. It has actually a negative effect on lipid profile, whereas the non-oral preparations do not have any effect at all. Some doctors use and must use antidepressants, as we know, SSRIs or SNRIs in women with contraindications to menopausal hormone therapy. Of all these regimens, fluoxetine and citalopram have either neutral or less detrimental effect on lipid profile. The other formulations, such as venlafaxine, duloxetine, may either increase total cholesterol or decrease HDL cholesterol. These modifications in lipid profile must also be kept in mind. So, taking all this data into consideration, the first step is to estimate the woman's 10-year risk for fatal cardiovascular disease. This may be assessed with some scores. One of the most commonly used in the European population is that provided by the European Society of Cardiology, the score system. You can use that, and according to the percentage that you will find for the woman, this woman can be classified either as very high, moderate, or low risk if she has documented arteriosclerotic cardiovascular disease or diabetes with end organ damage, or with a score above 10%. Whereas if she's if she suffers from type 2 diabetes with one additional risk factor, and if she has if she has familial hypercholesterolemia, or with moderate chronic kidney disease, or with a score between 5 and 10%, she will be diagnosed as high cardiovascular risk patient. Whereas for the other patients with a score between 1 and 5%, we have moderate risk, and when the calculated score is below 1%, the woman or man actually is categorized as low risk. This is very important because according to the categorization, the LDL target, which is the most important lipid parameter, is to be below 55, below 70 for high risk, below 100 for moderate risk, and below 160 milligrams per deciliter for low risk. And we should also take into account the other lipid parameters, such as non-HDL, ApoBeta, triglycerides, and LP-little-A, and try to achieve these targets as provided by the European Society of Cardiology, and to provide a kind of algorithm after assessing the woman's lipid profile and calculating her 10-year risk for cardiovascular disease, for fatal cardiovascular disease. You can see here that if she's at very high or high cardiovascular risk, we should avoid menopausal hormone therapy, and of course start a statin either alone or with ezetimibe or with PCSK9 inhibitor to reach the LDL cholesterol level. In cases with coexistence of triglycerides, of high triglycerides, despite statin, we should add either icosapentalyl ethyl at 4 grams per day, kind of omega-3 fatty acid, or a fibrate. If a woman is at moderate cardiovascular risk, we can use menopausal hormone therapy, preferring transdermal route. And of course, if the LDL target has not been achieved, we can use a statin or ezetimibe. In cases at low cardiovascular risk, we can take also lipoprotein little a into account. If it is high, that means higher than 50 milligrams per deciliter, we should consider oral instead of other preparations. And of course, if we have high triglycerides, as I mentioned before, we should use transdermal route. To conclude, transition to menopause is indeed associated with increased cardiovascular risk. Systemic estrogens induce a kind of dose-dependent decrease in total LDL and Lp(a) concentrations. They can also increase the HDL concentrations. This effect is more pronounced with oral estrogens, and transdermal is the preferred estrogen because compared with oral, it cannot increase, actually can decrease triglyceride levels. With regard to progestogen, we should use micronized or dihydrogesterone because these have a neutral effect on lipid profile. We can use tibolone because it may decrease total LDL cholesterol, triglycerides, and Lp(a), but we must keep in mind that it can also increase HDL. It can also decrease HDL concentrations. The other preparations have either subtle effect on lipid profile, such as low-dose vaginal estrogen and osteopifen. With regard to SSRIs, fluoxetine and citalopram exert a more favorable effect, and non-oral testosterone has little or no effect on lipid profile. You can also see these details in our published EMAS guide, published 2 years ago. Thank you very much for your kind attention.
So, dear ladies and gentlemen, my name is Dr. Armeni, and I am working as a honorary research fellow with the Second Department of Obstetrics and Gynecology at Ateon Hospital in Athens, Greece, for many years. I need to thank the organizing committee for this invitation to discuss menopause hormone treatment on atherosclerosis progression with all of you. Now, with regards to the pathophysiology of menopausal hormonal changes, aging and ovarian senescence is associated with a sharp decline in levels of estrogen and sex hormone binding globulin at the time of menopause. This results into an increase in the androgen to estrogen ratio. The environment of apparent androgenicity is associated with 4 different implications: metabolic and hormonal, impaired fibrinolysis, visceral adiposity, as previously mentioned, insulin resistance, and the hyperandrogenemia by itself. Impaired fibrinolysis has been associated with the early stages of atherosclerosis, which actually implies the thickening of the intima media wall of carotid and coronary arteries. Visceral adiposity in combination with insulin resistance can result into metabolic dysfunction, oxidative stress, and low-grade chronic inflammation, a condition and changes to which hyperandrogenemia has been shown to be an independent, direct, adverse predictor. All of these changes, together with the early thickening of the intima media thickness, result into the primary pathophysiological change observed in the vessel wall of postmenopausal women, which is the endothelial dysfunction. In vitro data has tried to explore the actual effect of estradiol administration to the vessels itself, the vasculature, and related pathophysiological changes. More specifically, data in mice has shown that estrogen administration can increase angiogenesis, improve vasodilation. With regards to fibrosis, it is known to suppress fibroblast migration and proliferation, and also to decrease the collagen deposition. Mitochondria seems to also benefit from an environment rich in estrogen because their survival is improved, apoptosis is reduced, free fatty acid oxidation is increased, improved, and the reactive oxygen species production is also suppressed. These changes contribute to a delay of the atherosclerotic process. An beneficial effect on oxidative stress overall with improved cell survival is also documented. We will move on by studying the effect of menopause itself to atherosclerotic changes so that we can later on explore the possible beneficial effects of hormone replacement therapy. A lot of cross-sectional studies, which are actually less than 5, but still a lot, have tried to explore the changes observed in endothelial function in women approaching the menopausal transition and also later on. These cross-sectional studies have shown that endothelial function is declining progressively with age since menopause and in parallel with the time since the onset of estrogen deficiency. In a study, longitudinal, that has been performed by a laboratory a few years ago, 180 postmenopausal women were investigated for an average of 29 months. We tried to explore changes in endothelial function over time. The results showed something quite interesting. The slope of the gradient with regards to flow-mediated dilation, which is a non-invasive marker indicative of changes in endothelial function, is always declining with time, but the rate of the decline is less steep in women with lower baseline androgen levels as opposed to women with higher baseline androgen levels. That means higher androgenicity at the time they entered the menopause. Arterial stiffness and the progression at the time of the menopause transition has been investigated by the study of women's health across the nation in 2020. The study aimed to investigate the percentage change in carotid femoral pulse wave velocity measured by time segments in relation to the final menstrual period. The results of this study are also quite interesting because they showed that arterial stiffness is slowly deteriorating with time up until 12 months before the final menstrual period. The slope of change is becoming more steep, deteriorating more sharply around the perimenopause, so from 12 months before up until 12 months after the final menstrual period, and subsequently the pulse wave velocity starts decreasing with time. The same study in another analysis tried to investigate as to whether or not the menopausal transition is associated with changes in vascular structure. In a sample of 249 perimenopausal women, followed up for a median of 3.7 years, the authors managed to confirm that the rate of progression in intima media thickness of the carotid artery was higher for women in the late perimenopausal stage as opposed to premenopausal or early perimenopausal women. This rate was also significantly higher compared to women in the postmenopausal stage. Trying to check as to whether or not there is a prediction or a direct association between the change in IMT values and the stage of reproductive life, they could not find a significant association, but the reason was related with the fact that adjustment did take place for the presence of cardiovascular risk factors. That means that without taking cardiovascular risk into account, in any case, late perimenopausal women do present with a higher progression rate in the thickening of carotid arteries. In another study done by a laboratory, we tried to investigate as to whether or not postmenopausal women without diabetes, but with a diagnosis of metabolic syndrome, do have any difference with regards to measures of subclinical atherosclerosis. Interestingly enough, we found difference with regards to common carotid artery thickness and combined carotid artery thickness. Both of them were found to be statistically significant and higher for women with the metabolic syndrome as opposed to those without the metabolic syndrome. Regression analysis confirmed the findings that the thickening of the carotid arteries is associated with features of the metabolic syndrome, like hyperglycemia, central obesity or dyslipidemia. So the metabolic syndrome by itself or its independent features does not positively affect subclinical atherosclerosis in menopause. Let's move on to HRT though. Observational studies on menopause hormone treatment and coronary heart disease during the late 1980 until 2000 did confirm positive findings with regards to estrogen use in women with angiographically defined coronary heart disease as opposed to non-users of estrogen, while others did show that menopause hormone therapy use was associated with improved fatal events with regards to cardiovascular disease, so lower rates of fatal cardiovascular disease, lower rates of mortality for those on unopposed estradiol treatment after the menopause. Therefore, WHI came along. This long-term randomized control trial of 27,347 postmenopausal women tried to clarify as to whether or not the combination of estrogen and progesterone or estrogen monotherapy would have a superior effect with regards to cardiovascular protection or not really. But unfortunately, the study, which consisted of an unselected population of older postmenopausal women, was terminated prematurely because of adverse events of breast cancer in the estrogen-progesterone arm and stroke risk in the estrogen-only arm. The reason has been investigated on multiple occasions, and subsequently the literature concluded on the fact that the difference is primarily related with the fact that women were old many times after the actual menopausal transition when they were started on treatment with menopause hormone therapy. Also, they had different cardiovascular risk considering it was an unselected population. The study presented in 2013 in JAMA showed that the actual absolute benefit with regards, absolute risk, with regards to coronary heart disease in women treated with estrogen and progesterone as opposed to estradiol monotherapy is improved, is beneficial for women started on treatment in the first 2 decades of the life after ovarian senescence, whilst starting treatment at an older age is not going to be associated with any improved profile with regards to cardiovascular disease. Cardiovascular events, coronary heart disease events should be anticipated. The same authors try to analyze the post-intervention risk for coronary heart disease and found that those women that were started on treatment at an age of 50 to 59 years did actually have a beneficial profile with only 5 cases presenting coronary heart disease events from those that were started on treatment with estrogen and progesterone, as opposed to a natural benefit of 11 cases less that would be anticipated to express coronary heart disease events for those on estrogen monotherapy. The same applies for women on treatment 60 to 69 years. Conclusion from this slide, treatment is beneficial, but the WHI was trying to tell us, try to start treatment earlier rather than later after the menopause. The KEEPS trial came along in order to try to investigate as to whether or not oral versus transdermal menopause hormone therapy is associated with any change in subclinical atherosclerosis as opposed to placebo. The results of the trial showed that the mean difference in the change of carotid intima media thickness was non-significant comparing oral treatment versus placebo and transdermal treatment versus placebo. In very simple words, no adverse effect noted with regards to subclinical atherosclerosis. The same study tried to investigate as to whether or not treatment has an adverse effect with regards to the change in coronary artery calcium, but once again no significant difference was noted. A little bit later, the ELITE trial tried to assess the hypothesis for which grounds were set by WHI as to whether or not early as opposed to late initiation of treatment would make any difference with regards to subclinical atherosclerosis in healthy postmenopausal women. This trial did manage to show a significant difference, an improved beneficial rate in the change of carotid intima media thickness for those on treatment with estradiol as opposed to placebo. Early initiators were the women that had a menopausal age until 6 years. Late initiators, more than 10 years. The difference in the slope is quite obvious. The red dots indicate early postmenopause on placebo. The blue dots indicate early postmenopausal women on estradiol. This study set the grounds for the timing hypothesis. The timing hypothesis is a hypothesis that was tried to be investigated by many authors, but the investigations and the studies on this aspect are still ongoing. Timing hypothesis means what is the window of opportunity to give HRT in a postmenopausal woman with regards to improving the cardiovascular risk. So this meta-regression analysis of 31 randomized controlled trials and 40,521 women showed that early initiation of HRT did actually protect from all-cause mortality. Early initiation of HRT was not significantly associated with cardiac mortality or all coronary events, and there was a slightly increased risk with regards to thrombosis in early as opposed to late initiators of treatment, but the profile and the overall risk was lower for those starting treatment earlier as opposed to those starting treatment later in life. One more analysis from WHI is trying to represent the absolute risk amongst women on conventional dose of menopause hormone therapy, stratified according to the age of menopause and the risk of presenting with different variations of cardiovascular disease. This analysis does confirm the previous hypothesis that women of the green bar, less than 5 years in menopause, have the best profile, while those that were started on treatment after 20 years into the menopause have the highest risk. Coming to the end, a very recent and interesting study was published in May 2021, representing once again a reanalysis of the WHI. This study tried to estimate predictors of cardiovascular risk, considering the actual cardiovascular risk as a possible reason for the different expression, the different outcomes with regards to the women, those women that were treated with menopause hormone therapy. The study managed to show that age, as expected, is a risk factor for cardiovascular risk. Yes, since menopause is one more, but the strongest of them all is the baseline cardiovascular disease risk at the time of actually transitioning into the menopause. The study showed that women with a higher calculated cardiovascular disease score at the time of entering the menopause have the highest risk for incident cardiovascular disease events as opposed to those with a better metabolic profile at the time of entering the menopause. Thank you very much, and don't forget to assess your cardiovascular risk when prescribing hormone replacement therapy.